Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI Oncology Tumor Board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. This is a patient, 59-year-old male with stage 4 colorectal cancer with metastases to the liver. Patient had an abdominoperineal resection and treated with 2 lines of systemic therapy, most recently with progression on FOLFOXIRI and bevacizumab. So what is the next recommended treatment option, and would the panel have actually treated this patient in a slightly different way? So this patient presented with rectal pain, fatigue, abdominal pain, decreased appetite, and loose stools, and a weight loss over the course of 3 months, but otherwise had a relatively decent performance status. Patient did have a history of diabetes, hypertension, and chronic kidney disease, as well as being a smoker with 10 to 12 cigarettes per day. And the patient had a family history of hepatocellular cancer in his father. At the initial time of diagnosis, the patient was found to have a small pink fungating mass that was visible on anal inspection about 1 centimeter into the anal canal. But then on colonoscopy, there was a second polypoid stenosing tumor starting at 16 centimeters from the anal verge, extending proximally to the mid-sigmoid colon and across which the scope was able to pass, but with some mild resistance. And an FNA of the cytology, the anal mass, did show an adenocarcinoma, not a squamous cell cancer. And an MRI of the pelvis showed 2 lesions, one in the anal canal, as mentioned, and the second in the rectosigmoid junction. A CT scan also showed a locally infiltrated left hepatic lesion with associated angioinvasive component involving the left main portal vein, suggestive of a metastatic lesion, as well as small indeterminate pulmonary nodules. A liver biopsy did confirm metastatic adenocarcinoma. The patient underwent an APR, an abdominal perineal resection, and the tumor pathology revealed the first tumor to be 1 centimeter in size and the second tumor to be 2.5 centimeter in size. It was a grade 2 adenocarcinoma with 4 out of 21 local lymph nodes involved, PT4 and 2A. Laparoscopically, the patient also underwent an ultrasound of the liver at the time of APR, which revealed the metastatic disease involving the left lobe of the liver crossing the falciform ligament involving segment 4, and the left portal vein was also involved by tumor, and the hepatobiliary surgeon who was there recommended the patient getting some chemotherapy, followed by a reassessment for left hemihepatectomy. So before we move on to the next slide, Dr. Patel, I wanted to ask you if this is a patient with metastatic disease who was first treated with an APR, an abdominal perineal resection, which is obviously a very, very big operation and commits the patient to a lifelong ostomy. But under what circumstances might you consider incorporating palliative radiation, for example, to a patient who's bleeding or who's nearly but not totally obstructed at presentation? And if you were to use palliative radiation, what kind might you use? Short course versus long course, et cetera?
I think this is a challenging case with sort of a rectal, but really an anal adenocarcinoma, which is quite rare, and a synchronous sigmoid tumor. I think a discussion with really the tumor board here is critical. When we decide about using palliative radiation in a case like this, we're typically using a regimen that more resembles a short course treatment. So certainly with no concurrent chemo, and in this case, maybe only targeting the area where the symptoms are coming from, if that can be determined. But there's also the possibility of, other treatments if systemic therapy is going to be used. I mean, I think, for example, pain or a sort of mild bleeding sometimes responds really well, even just to the first cycle of systemic therapy. So some of I think some of that decision making depends on the sort of severity of the symptom and what the whole team thinks about sort of the urgency. But palliative radiation, I think, is often used for bleeding in particular. It can be very effective and very quickly helpful in that situation. Not so much for obstruction, but for bleeding or pain, certainly, I think there's a good chance that palliative radiation can help quickly. And it would be a treatment that's, as you say, a palliative treatment. That means we're typically not targeting any of the elective nodes. It's a small volume of treatment. Again, not sort of what you would think of as short course. Short course radiation is really a definitive intent, large field, the elective lymph node areas, the presacral space, all included. And in a palliative mode, we probably wouldn't do that. We would be in a much smaller area of treatment, but a similar timeline, probably just a week's course of radiation.
But actually, just for my education, does it take less time to do the planning for a palliative radiation course than a short course definitive therapy?
It can. I think we're more and more we're wanting to use every advanced radiation technique that's appropriate for each case. So if you're in a definitive mode, you might use an advanced technique like intensity modulated radiation. I mean, there's some interest even in proton radiation to minimize exposure to the other organs. But in a palliative case, it should be a faster planning time because, in that case, there's an urgent indication for radiation. And so in that case, I think we're more often using, a three-dimensional technique, a lower dose, such that advanced planning techniques are not needed because the toxicity profile is favorable.
Gotcha. All right. So moving on to the next slide and a couple of questions that I had. So first of all, we've talked a little bit about whether we would have treated this patient slightly differently and whether the molecular profiling would have modified the treatment decision. But Dr. Weiser, I wanted to ask you a question. We don't unfortunately have the baseline images, but in the description, what was your perspective of the key factors that made this patient not an ideal candidate for an upfront partial hepatectomy? And if you'd like, I'd be happy to return to that slide that discussed this laparoscopic look at the liver.
Yeah, I think the vessel invasion can be concerning, although could be incorporated with resection. I would say in this case in general, although I believe it's an octogenarian, if they were fit, of course, physical sort of age is much more important than chronologic. I think although this is quite an appropriate course of treatment, maybe starting with chemotherapy could have had quite a good response on the stenosis in the rectosigmoid, as well as a response in the liver, so that we could then move on to a combined resection, with or without radiation, depending on the extent of disease.
And do you ever consider incorporating additional local therapy to the liver, such as radioembolization, to render the liver lesions operable?
Usually we've had very good success with standard systemic chemotherapy, with the majority of tumors responding sufficiently. Of course, I come from a place that uses a lot of regional therapy in the liver in the form of intrahepatic artery pump treatment. And we do in multi-stage procedures, resection with placement of intrahepatic artery pump to help make the remaining liver resectable. Of course, that's not available in all settings and can be controversial.
Very good. Dr. Wainberg, this was a relatively young patient with two synchronous, if I'm remembering correctly, with two synchronous colorectal cancers. Wouldn't MMR testing be critical? And if the results came back that the patient had an MSI high or MMR deficient colorectal cancer before any definitive therapy was done, would it change the way you manage the patient?
Yeah, so I think that, if microsatellite instability was confirmed based on either IHC or PCR in this patient, one would start sooner with immunotherapy. That's based on the recent report of a randomized phase 3 trial comparing any standard chemotherapy to single-agent pembrolizumab that showed a clear advantage to the use of pembrolizumab in that context. Some people also would consider double immune blockade, such as nivolumab and PD-1 inhibitor and ipilimumab, a C2A4 inhibitor, although there really isn't randomized data supporting that over single agent checkpoint blockade. But there is now finally very compelling data that if you do have confirmation of microsatellite instability with metastatic disease, you would indeed not start with chemotherapy, unless there's a reason not to give the immunotherapy, of course.
Okay, so this patient did get treated with 6 cycles of modified FOLFOX, 5-FU leucovorin-oxaliplatin. The treatment was discontinued due to neuropathy, but we really don't know how long the treatment-free or progression-free interval was. Ultimately, they did have a treatment response, as well as reduction in the site of the both hepatic and pulmonary metastases. And I think because the pulmonary metastases shrunk, there was not a discussion or decision to move on to hepatectomy. The patient started maintenance chemotherapy with just 5-FU on its own, and then follow-up CT scans did eventually show disease progression with increased number and size of the pulmonary metastases, unchanged hepatic metastases, and so the patient was started on second-line therapy with 5-FU, irinotecan, leucovorin, and bevacizumab, or FOLFIRI bevacizumab. And then finally, most recently, the patient did have progression on that regimen. Before we move on to the next slide and to the images, Dr. Weinberg, what is your opinion now in 2021 of FOLFOXIRI plus antibody versus doublet therapy plus antibody for patients with incurable metastatic disease?
Yeah, it's a good question, and you know, the most important thing to know here is, are we talking about a KRAS wild type tumor? It's really critical, and I don't recall that we had any of that information on this particular patient, but this would be the situation where we would really want to get, at the very least, as we mentioned earlier, MSI status, but also of great importance would be KRAS BRAF. And the reason for that is we're talking about a left-sided tumor with multifocal disease and metastatic disease, in which there's a clear benefit to an anti-EGFR antibody as it relates to survival and response rate. So certainly by second-line therapy, and first line is controversial, whether there's improvement of an anti-EGFR over standard doublet such as FOLFOX. One would consider the addition of an anti-EGFR antibody, perhaps even more important in a case like this, where response rate is important if we were dealing with aggressive biology. The role of FOLFOXIRI, which is also a triplet often used in younger patients, or FOLFOXIRI and bevacizumab for that matter, is that there have been randomized data sets showing improvement of survival in FOLFOXIRI over FOLFIRI alone. So that's certainly a reasonable option as well. It really ultimately depends on the performance status of the patient, the goal of therapy, and trying to assure response rate as an important primary endpoint. So for example, a response rate of FOLFOXIRI associated with 70%, a much greater response rate than the 40-50% one would expect with a doublet chemotherapy antibody combination. So it has to be individualized to the goal of therapy for that particular patient. But in a left-sided RAS wild-type tumor, I would equally think about the addition of a anti-EGFR antibody such as cetuximab or panitumumab to the doublet chemotherapy regimen as a goal also to increase response rate and survival.
Very good, thanks for that. Dr. Siegel, this is the pulmonary imaging.
So these are just some images from the upper and the lower lungs, just showing really innumerable pulmonary nodules. The nodules in the lower lungs are bigger, and there's more of them than the upper lungs, just consistent with the patient's known metastatic disease.
Yeah, we were just having this discussion recently that a patient who has a scan like this, you're really hoping that the tumors and the nodules in the lungs don't change either way. They don't grow, but they also don't necessarily shrink with preoperative chemotherapy.
Yes.
So, all right, so moving on to some additional questions. We've covered a lot of this actually, so I'm going to skip over a couple of these questions, but the main thing really is for a patient who's progressed on or is no longer tolerant of FOLFOX and then FOLFIRI and bevacizumab, what would we recommend for third-line treatment, and what molecular testing in addition to the KRAS testing and the MMR testing that you talked about, Dr. Weinberg, what else would you want to be testing for in deciding third-line therapy?
I mean, in truth, while we do send for next generation sequencing sometimes in patients in this context, the most important things are, as we mentioned, KRAS, BRAF, and MSI testing. Now, because each of those would have a practical treatment option for this patient. In the case of a KRAS wild type, BRAF wild type patient, you would consider an EGFR inhibitor at this point. There's survival advantage of those drugs in that context in third line. In the case of a BRAF mutation patient, you would consider BRAF inhibitor and Regorafenib and cetuximab in this context as well. And of course, as we mentioned, a PD-1 inhibitor if they're MSI. Outside of that, the possibility of an actionable biomarker is very low. There are circumstances where an NTRK fusion is seen and where you would consider one of those agents, or a RET alteration, which is also exceedingly rare. But most importantly, to get the basic molecular testing. If all of those are negative, and the patient is in this third line, so-called third line context, and clearly has progressed on oxaliplatin and irinotecan-based therapy, we do have two FDA-approved agents in the United States, Regorafenib, which is a multi-targeted TKI, and of course, triptazine fluorouracil, otherwise known as TAS-102, which is a fluoropyrimidine derivative, which also has an improvement in survival over placebo alone, which would represent a systemic therapy option for this patient.
Very good. Hey, Dr. Weinberg, do you use the recourse, I think it's called, a redose paradigm that with starting at 80 milligrams of regorafenib and then working its way up?
Yes, I do, and that's been studied pretty well, I think, in randomized phase 2 study, comparing the redose strategy, starting at 80 milligrams and increasing a month later to 120, or excuse me, a week later to 120 milligrams. And the 160 milligram dose level of regorafenib for many patients is simply intolerable, and I don't routinely start that anymore at all. No matter the performance status, I start them on 80 milligrams if it's well tolerated, make my way up to 160 rather than vice versa, because I find that the package label of 160 milligrams is a very difficult dose level for most patients in this situation. So I like the redose strategy, and it's good to have confirmatory data showing that it doesn't jeopardize efficacy while preserving toxicity improvements.
Good. Yeah, I do the same, so I agree. So I think this was a complicated case, but to try and focus on some of the specific questions, the panel recommended that partial hepatectomy could be definitely considered, but I think the trumping issue in this patient were the pulmonary nodules that unfortunately got a little bit smaller and then eventually later grew a little bit. We talked a little bit about the role for non-surgical liver-directed therapies, whether it's radiation therapy or intra-arterial therapy. But overall, I think that this patient would have been treated similarly with very subtle differences that are really, you have to be in front of the patient to make those decisions. And then as far as third line therapy, there really are two standard third line therapies available, at least in the United States, Regorafenib and TAS-102. I will say, and I'm sure Dr. Weinberg will agree, that a lot of this will also look for clinical trials for exactly this kind of patient in exactly this space in the third line setting.